patients who are geriatric and pediatric patients, patients who are very young or very old, patients who are confused in critical condition, patient who has lots of pain because pain distracts patient, and also patients who don't speak English. They are patients who are at risk of misidentification. Different antibiotics affect different parts of bacteria. This is a picture from your book. Bacteria have a cell wall unlike us. So animal cells like human cells, we don't have cell wall. We have only plasma membrane. But a lot of bacteria have a cell wall, and some antibiotics block or inhibits formation of bacterial cell walls. The most important mechanism of action that you need to know are antibiotics that block or inhibit cell wall formation. That would be penicillins, cephalosporins, vancomycin, and carbapenem. So almost all famous antibiotics. Penicillins, all cephalosporins, vancomycin, that is specifically important for treatment of methicillin-resistant Staph aureus, and carbapenem, like imipenem cilastatin. They all work to block formation of bacterial cell wall. Some of the antibiotics block formation of protein synthesis, like aminoglycosides. Aminoglycosides like gentamicin, amikacin, they all block formation of protein synthesis. So, for example, sometimes you get a mixture of questions. For example, which antibiotic that inhibits formation of bacterial cell wall can be a treatment for Clostridium difficile, for C. diff. And you will know that two antibiotics can help for treatment of Clostridium difficile, vancomycin and metronidazole. Which one is an inhibitor of formation of bacterial cell wall? Vancomycin. So you choose vancomycin. So remember, penicillins, cephalosporins, vancomycin, and carbapenem, they block or inhibit formation of bacterial cell wall. This is their mechanism of actions. Aminoglycosides, they block protein synthesis. Penicillins, all of them have suffix -cillins, even piperacillin, tazobactam, amoxicillin, clavulanic acid, even if they have another adjuvant antibiotic with them, but still you consider them as penicillin family. And very important to know about the allergic reaction. So allergic reaction, if patient only shows some hives or some urticaria, your first line of treatment would be antihistamine. So if your patient only have a skin rash after antibiotics, every antibiotics or even penicillin, but patient doesn't have edema, swelling, wheezing, this patient, you may give patient only antihistamine. But if patient has anaphylaxis, what is anaphylaxis? Patient has swelling of tongue, swelling of respiratory tract, and patient cannot breathe. You hear wheezing. When you listen to your patient lung, you hear wheezing. This patient has anaphylaxis and your treatment would be epinephrine. So depends on which type of allergic reaction you have to penicillin or other medications, you choose your treatment. If patient only shows rash and urticaria, your first line of treatment would be antihistamines. If your patient has wheezing, you can hear wheezing, patient has edema in face, in tongue, problem in breathing, low blood pressure. If it's anaphylaxis, then your treatment would be epinephrine because antihistamines won't work. And we have cephalosporins families, start with prefix ceph, like cephalexin, like ceftriaxone, like cefpm. Remember, cephalosporins are only group of antibiotics that have 4 generations, first generation, second, third, and fourth generation of cephalosporins. And as you go from first generation to fourth generation, they would be more effective against gram-negatives. Cephalosporins, very important, have cross sensitivity with penicillin. So if your patient is allergic to penicillins, any penicillins, ampicillin, amoxicillin, then you cannot give cephalosporins to this patient. If a patient is allergic to penicillin, means patient never can take cephalosporins. Instead, you can give, for example, erythromycin, azithromycin. These medications are substitute for penicillin. Imipenem, carbapenems also work by blocking formation of bacterial cell wall. Carbapenems like imipenem cilastatin, like meropenem. Important side effects of imipenem cilastatin is seizure. So if you have a patient with history of seizure, you won't give this patient imipenem cilastatin. Vancomycin is very important antibiotics. Despite all side effects like ototoxicity, nephrotoxicity, Redman syndrome, we still choose vancomycin a lot of time as a first choice before our blood culture or, for example, CSF culture returns back. You need to start vancomycin and another antibiotics because vancomycin is effective against methicillin resistance staph aureus. So vancomycin is still very important antibiotic. So you need to know about side effects and adverse effects. First of all, you need to infuse vancomycin in longer than 1 hour. So if you give infusion of vancomycin very quickly, less than 1 hour, then patient develops Redman syndrome, rash and urticaria in face, chest, and neck. But Redman syndrome is not a contraindication for vancomycin. You just slow down rate of infusion. Two important adverse effects, in fact, would be ototoxicity and nephrotoxicity. So if patient takes vancomycin, you need to ask your patient report any hearing problem and check patient's BUN and creatinine every other days to make sure patient is not developing nephrotoxicity. Aminoglycosides have the same side effects of and adverse effects of vancomycin, nephrotoxicity and ototoxicity. And a lot of time we give a combination of aminoglycosides and vancomycin. Most of the time, if you check antibiotic regimen for a patient who is in ICU, you will see vancomycin plus gentamicin plus ceftriaxone. So a lot of time, vancomycin, you give them with aminoglycoside together as a combination. So the nephrotoxicity and ototoxicity increases, risk of ototoxicity and nephrotoxicity increases. Ask your patient to report any hearing problem, tinnitus, and also check patient BUN and creatinine level. Aminoglycosides, again, they block protein formation. What is the mechanism of actions of aminoglycosides like gentamicin, like streptomycin? They block protein synthesis in bacteria. Aminoglycosides, they cannot be absorbed via GI tract. So you give them either via IV or IM injection. So what is superinfection or opportunistic infection? When you give antibiotic to your patient to kill, you kill also normal flora. What are normal flora? Trillions and trillions of bacteria that live inside of our large intestine, live on the surface of our skin, live inside of our nose, inside of our mouth. When you kill those normal flora, then there would be more oxygen, more nutrient for bad bacteria, for fungi even. So we have overgrowth of fungi inside of the mouth, inside of the vagina, or even more dangerous bacteria, superinfection, Clostridium difficile. What is Clostridium difficile? Usually, when you give antibiotics, a combination of, most of the time, a combination of antibiotics and more than 1 week, 2 weeks. It may happen quickly, but in regular scenario is your patient is taking several antibiotics for 2 weeks, 3 weeks, and all of a sudden, patient develops fever, very toxic situation. Patient would be very toxic, cannot eat, cannot drink.
patient will have very severe diarrhea and even bloody diarrhea. What should you do if you are suspicious to Clostridium difficile? You need to hold all antibiotics. So you stop all antibiotics, send the stool culture, and then start vancomycin or metronidazole or a combination of them. And remember, vancomycin PO, metronidazole PO by mouth. If you give them IV or IM, they are not effective against Clostridium difficile. So for the treatment of Clostridium difficile, stop all antibiotics, send the stool culture, and start vancomycin and metronidazole PO by mouth. Vancomycin, remember, it's a inhibitor of cell wall synthesis, bacterial cell wall synthesis. Tuberculosis, patient catches tuberculosis via respiratory droplets, either via sneezing, coughing, talking. So a patient who has tuberculosis, most likely active tuberculosis, can disseminate tuberculosis to another patient. Some people shows active tuberculosis. Some patients who have a strong immune system, their immune system localize tuberculosis infection in a corner. But still this patient might be effective for another one. Or this patient may shows active tuberculosis once in a time, at the time that, for example, when you receive glucocorticoids or DMARDs, then the localized tuberculosis might be activated. So when you want to work as a healthcare professional, or when you want to work in daycare center, you need to have tuberculin skin test. How do you know to check if patient has a localized and limited tuberculosis or not? So you inject intradermal skin test of tuberculin skin test and read it after 48 or 72 hours. What you consider as a positive tuberculin test when patient has more than 10 millimeter in duration? So it's not only redness. In duration means hardness and redness together. Hardness and redness. So if patient has more than 10 millimeter in duration, this patient has a positive tuberculin test. You send patient for chest X-ray and other evaluation. Treatment of tuberculosis, because Mycobacterium tuberculosis have very slow reproduction time, even sometimes several weeks. You need to treat your patient for several months. A combination of these drugs, isoniazid, rifampin, pyrazinamide, and ethambutyl, even sometimes you add streptomycin, for 9 to 12 months. Most of the time, the first 2 or 3 months, this patient takes all of them, and then you continue isoniazid and rifampin. All of them are hepatotoxic. So before you start anti-tuberculosis treatment, you need to check liver function test, AST and ALT, see if patient at the first place has liver dysfunction or not. If patient is okay and you start this medication, advise your patient, don't drink alcohol. Don't take acetaminophen and other over-the-counter medications, because a lot of over-the-counter medications have acetaminophen that are hepatotoxic. So don't combine anti-tuberculosis medication with alcohol, acetaminophen, and over-the-counter medication. Report any sign and symptoms of liver dysfunction. That would be nausea and vomiting, weight loss, jaundice, yellowish skin. If you experience each of them, you need to come to the emergency room or to the clinic to check your liver function. Isoniazid should be given with vitamin B6 complement. Why? Because isoniazid interferes with the absorption of vitamin B6. So patient may develop neuropathy. So isoniazid, side effects of isoniazid would be hepatotoxicity plus neuropathy. To prevent neuropathy with isoniazid, you should give your patient vitamin B6 supplement. Pyrazinamide is hepatotoxic. Rifampin has very unique side effects. Orange discoloration of all body secretion. So patient who takes rifampin, other than hepatotoxicity and some level of nephrotoxicity, patient develops orange discoloration of tear, saliva, sweat, all body secretions, urine, all of them turns orange. Ethambutol may cause optic neuropathy, means you need to check your patient visual acuity every month at least. Fungal infection, you give antifungal infections for infection with fungi because fungi, they don't respond to regular antibiotics. This is why a lot of time fungi are super infection, are opportunistic infections. When you give antibiotics to a child, for example, for 2 weeks, then child develops these, for example, cheese-like, cottage cheese-like exudate inside of the mouth. This is oral candidiasis. Then you give your patient antifungal medication, different antifungal medications. A lot of antifungal medications have suffix azole. We call them azoles, like fluconazole, like ketoconazole. They have suffix azole, so we call them azoles. Like fluconazole, ketoconazoles, they might be tablets, like most of the time you see fluconazole tablets, or ointment like ketoconazole for different infection. Then we have nystatin. Nystatin is very famous antifungal medication because you give oral solution of nystatin for oral candidiasis and you give vaginal nystatin for vaginal candidiasis. So nystatin is very commonly used antifungal medication. If your patient has oral candidiasis, you give solution of nystatin solution, for example, 600,000 units every 6 hours. Patient needs to rinse their mouth and swallows it to reach the nystatin to the esophagus too. For vaginal candidiasis, you give vaginal cream, nystatin vaginal cream. Antifungal medication, we have also another one, amphotericin B. Amphotericin B you give for life-threatening fungal infection, like patient who has endocarditis, patient who has meningitis with fungal infection. So amphotericin B is not an antifungal drug that you give your patient at home. It's only for life-threatening infection. Patient who takes antifungal medication, advise your patient to report any skin rash, because skin rash, sore throat, they all might be because of severe allergic reaction. So skin rash, sore throat, urticaria, you should be reported. And of course, patient who takes antifungal medication should avoid alcohol because alcohol is hepatotoxic. Glucocorticoids, they have suffix zone or zolon most of the time, not all the time. For example, triamcinolone doesn't have zone or zolon, but triamcinolone is still a glucocorticoid. Like dexamethasone, betamethasone, triamcinolone, prednisolone, they are glucocorticoids. Our adrenal gland make these glucocorticoids inside of the body. So when you give glucocorticoids as a medication from the outside, adrenal gland stops making glucocorticoids because now you have enough glucocorticoid inside of your body. So you never should stop glucocorticoids abruptly. If your patient has been taking glucocorticoids for 6 months, now patient doesn't have any asthma attack and you want to stop prednisolone, you cannot stop it abruptly. You need to decrease the dose during several weeks or even several months. And in fact, you need to taper it down slowly. Otherwise, your patient develops acute adrenal insufficiency. Acute adrenal insufficiency with this severe nausea and vomiting, diarrhea, very low blood pressure, and even shock. Other side effects of glucocorticoids. So glucocorticoids like dexamethasone, prednisolone, betamethasone, even inhaled glucocorticoids like budesonide, like fluticasone, you cannot stop them abruptly. You need to taper them down slowly. Other side effects, abnormal fat distribution, like buffalo hump, like moon face, abnormal fat distribution. Patient gains weight, so weight gain. You need to weight your patient every day at the same time. Patient develops high blood sugar level and high blood pressure. So glucocorticoids increase patient's blood pressure and patient's blood glucose level. And other side effects like suppress immune system, suppression of the immune system. So you need to be cautious about signs and symptoms of infection. Also osteoporosis, thin skin, thin hair. They are all side effects and adverse effects of glucocorticoids. Hyper secretion of glucocorticoids inside of the body, or if you give your patient too much glucocorticoids, causes Cushing syndrome. This is a patient with Cushing syndrome. So patient has high blood sugar level, high blood pressure, abnormal fat distribution, weight gain, a weak immune system, thin skin, thin hair, osteoporosis. They are all signs and symptoms of a Cushing syndrome. For inhaled corticosteroids that you give for treatment of asthma. For treatment of asthma, if you remember from Pharmacology 1, you gave your patient some anti-inflammatory drugs like glucocorticoids, like, for example, antihistamines to decrease the swelling inside of the respiratory tract. And also you give your patient bronchodilators, like, for example, albuterol, that is short-acting beta-2 agonist, or salmeterol, that is long-acting beta-2 agonist. For other inhalers like salmeterol, you advise your patient to wash your inhaler twice a week or every other day. But for glucocorticoids, inhaled glucocorticoids, patients should wash the inhaler every single time that they use it. Why? Because glucocorticoids suppress the immune system and strongly increase risk for fungi infection, candidiasis inside of the mouth and inside of the esophagus. So patient who takes, for example, fluticasone as a inhaled glucocorticoid, like fluticasone, like beclomethasone, they are inhaled glucocorticoids. Patient should wash the inhaler every time he or she is using it, and then patient should rinse the mouth and spit it out. So when you inhale, use the, for example, fluticasone inhaler, you should rinse your mouth with water and spit it out. NSAIDs, we have two types of NSAIDs, non-selective NSAIDs like aspirin, ibuprofen, they block both cyclooxygenase 1 and cyclooxygenase 2. And we have selective COX-2 inhibitors. Selective COX-2 inhibitors, celecoxib and meloxicam. Remember these two. Selective cyclooxygenase 2 inhibitor, celecoxib and meloxicam. These two only block cyclooxygenase 2. They don't have that much of risk for bleeding like aspirin, but they increase risk for myocardial infarction and stroke. Also remember, we talked about it in Pharmacology 1, all NSAIDs are bad for heart except for aspirin. So aspirin is an exception that you give your patient with heart disease. Other NSAIDs, specifically celecoxib and meloxicam, are very bad for heart. So you need to advise your patient report any chest pain. Now return back to the previous slide. What happens if patient swallows plenty of aspirin tablets by mistake or, for example, for suicide? Then patient develops salicylism. Salicylism is aspirin toxicity. Signs and symptoms of salicylism. Patient has tinnitus, headache, dizziness, fever, don't forget fever. So if patient has salicylism, patient has fever, not low body temperature. Patient's body temperature increases. Patient has respiratory suppression. Even if patient has fast respiratory rate or hyperventilation, but still it's not effective and patient has respiratory suppression. So tinnitus, patient will have fever, headache, dizziness, increased temperature or fever, and patient will have respiratory suppression. At the same time, tachypnea, fast or hyperventilation. NSAIDs, they all increase risk for bleeding. So patients should take NSAIDs like aspirin, ibuprofen with food, not an empty stomach, and with a full glass of water. And if patient has history of peptic ulcer disease, patient shouldn't take NSAID. You don't give aspirin to young children. Why? Because they may develop Ray's syndrome. So if a mother says that my child already took aspirin and nothing happens, you still shouldn't give aspirin to that child because it's a rare but very dangerous situation, inflammation of brain and liver. So children, if they have fever, they can take acetaminophen, but not aspirin. What is sickle cell disease? Sickle cell disease patient, because of an abnormal amino acid inside of the hemoglobin, instead of hemoglobin A and hemoglobin B, patient has hemoglobin S. Plenty of hemoglobin S that causes red blood cells to be like a crescent. So normal red blood cells, they are like a disc, but patient who has sickle cell anemia, their red blood cells are like a crescent, like a sickle. What happened is abnormal red blood cells stuck inside of very small blood vessels and create vaso-occlusive crisis. So what is vaso-occlusive crisis? Vaso means blood vessels, occlusive means closure, and crisis means crisis. So vaso-occlusive crisis happens in patient with sickle cell anemia. Patient develops very severe pain, like in chest, in hand, in feet, or even causes a stroke in a patient who is very young, even a child. What should you do in vaso-occlusive disorder, vaso-occlusive crisis? At the emergency room, you should give your patient oxygen, so even 100% oxygen, plenty of fluids, and also analgesic because patient has lots of pain. So treatment of a vaso-occlusive crisis in a patient with sickle cell anemia would be hydration, lots of fluids, oxygen, and analgesic, painkillers. Different medication for treatment of pain, for example, opioids. Opioids or opioid agonists, they most likely affect the mu receptors and they are strong painkillers. All opioids are controlled substances, so they are highly might be addictive and patient may abuse them. So they are all controlled substances, some of them more, some of them less. For example, codeine is in lower level, fentanyl, morphine, they are in higher level. What are side effects and adverse effects of opioids? So, opioids causes constipation, of course, sedation, low blood pressure, and low body temperature. So patient who is addicted to the opioids, they always have low blood pressure. They always have cold skin. They always have constipation. And they are not as alert as you are. They are a lot of time sedated. They are drowsy. There is another side effect that is very dangerous. This is bradypnea. Bradypnea means slow respiratory rate. And this is what kills patients. You have heard a lot about fentanyl toxicity and fentanyl deaths. Why fentanyl or morphine or other opioids kill patients? Because of bradypnea. Patient will have very slow respiratory rate. Instead of having more than 22 breathing per minute, patient might have breathing rate, respiratory rate less than 12 breathing per minute, or even very dangerously, less than 8 breathing per minute. This is bradypnea. What should you do? You should give the antidote. What is antidote of opioids? Naloxone. So if you give your patient morphine, if you are giving your patient fentanyl, you should have antidote that is naloxone ready. Okay, so any high alert drugs that are high alert, pinch, remember pinch. One of the high alert drugs are opioids. Another one is heparin. Another one is insulin. So when you give opioid to your patient, you should have antidote ready. Heparin, you should have antidote. Insulin, you should have glucose. Antidote of opioids is naloxone. So side effects of acute or sign and symptoms of acute opioid toxicity. Patient has constipation, low body temperature, low blood pressure, and sedation. But the dangerous one is bradypnea, a slow respiratory rate that patient eventually stop breathing. Specifically, respiratory rate less than 8 per minute. That is very dangerous, but still less than 12 breathing per minute, you consider it as very severe opioid toxicity. And antidote is naloxone. Naloxone, you give naloxone and antagonize morphine. But remember, naloxone has very short half-life, maybe 1 hour. But morphine, fentanyl, they have longer half-life. So if your patient is in severe opioid toxicity, you cannot give one naloxone shot and leave your patient. Someone should stay on patient's bedside and give another shot of naloxone and another one every time the respiratory rate drops under 12 per minute. If patient has pain, almost all patients have pain after the surgery. This is called post-operative or incisional pain. What should you do? You should ask, because patients have different tolerance to the pain and different level of pain. You should ask your patient to rate your pain from a scale from 0 to 10, that 10 is the worst pain that you have ever experienced. How do you rate your pain? If patient rate his or her pain at level 3, then you can give acetaminophen or NSAIDs if patient doesn't have bleed. But if patient rates pain level at 9 or 10, then you give your patient opioids like morphine, like fentanyl, like hydrocodone. Acetaminophen or Tylenol. Tylenol is the brand name. Acetaminophen is over-the-counter medication. Sounds innocent drug, but it's not. It's in fact very hepatotoxic, specifically if patient takes toxic dose of Tylenol, for example, in attempt for suicide. Then Tylenol causes acute liver necrosis that even patient needs a liver transplant. Acute liver necrosis means all liver cells are going to die. And it happens in few hours. When patient takes acetaminophen, first sign and symptoms of toxicity would be nausea, vomiting, and abdominal pain. Abdominal pain in this patient with Tylenol toxicity, with acetaminophen toxicity, means patient is developing a liver necrosis. So what should you do? You give antidote of Tylenol, that is N-acetylcysteine. So when patient takes too many acetaminophen pills, patient has nausea, vomiting, abdominal pain, and diarrhea, means patient is going to have a severe liver toxicity or liver necrosis. You give your patient N-acetylcysteine. N-acetylcysteine, you should give it as soon as possible. If it passed several hours, then N-acetylcysteine might not work properly. So give the antidote of acetaminophen and acetylcysteine as soon as possible. Then other miscellaneous painkillers or treatment for pains like almatriptan. All tripans, the suffix tripans, are treatment for a kind of treatment for migraine. There are different migraines for treatment for migraines, depends on patient's tolerance. Like some patients only respond to the morphine or fentanyl. Some patients may respond to prophylaxis with beta blockers or even acetaminophen. While almatriptan is a drug for treatment of migraine, it's an agonist of 5-hydroxytryptamine. So blocks this agonized or increased activity of 5-hydroxytryptamine receptors, and it's a treatment for migraine. How does it work? How do you know that it's working for this patient? Patient should have some relief in 2 hours. So when you give almatriptan, patient usually starts feeling some relief after 2 hours. Proton pump inhibitors are the strongest drugs that block acid-making pumps. There are some acid-making pumps or hydrogen pumps inside of our stomach that make acid. Proton pump inhibitors block acid-forming pumps inside of the stomach and strongly block production of acid. They are the best treatment for peptic ulcer disease, for stress ulcer, and even for gastritis. They have suffix prozole. So if you remember one of them, you can recognize all of them, omeprazole. So omeprazole is the most common one, suffix prozole. So pantoprazole, esomeprazole, lansoprazole, they are all proton pump inhibitors. What is the best treatment for or for prevention for peptic ulcer and stress ulcer? Proton pump inhibitors like pantoprazole. You give after any major surgery. Nowadays, you give pantoprazole or lansoprazole to patients to prevent stress ulcer. What would be side effects? Whenever you block acid formation, you increase chance for pneumonia, because there are some bacteria inside of our pharynx, throat, that stomach acid kills them. If you block production of acid, there is a higher chance for us to swallow those bacteria and get pneumonia. Also, esomeprazole, pantoprazole, they block absorption of calcium. So patient may develop osteoporosis and increased risk for fracture. So proton pump inhibitors, they increase risk for pneumonia and they increase risk for osteoporosis and fracture because they interfere with absorption of calcium. Diuretics. What are diuretics? Diuretics are drugs that make your patient to urinate more, to pee more. Indications of diuretic you give for patient who has a fluid overload, like patient who has edema, patient who has pulmonary edema, patient who has edema in ascites, you give them diuretics. Patient who has high blood pressure, diuretics could be antihypertensive too. Or give to patient to decrease intracranial pressure, like mannitol, intraocular pressure, like acetazolamide. So diuretics, we have different groups of diuretics, different types of diuretics. All of them make patient to pee more. So your patient who takes diuretics needs to go to the restroom, or you need to place Foley catheter for your patient because they will urinate a lot. Different types of diuretics. We have loop diuretics that affect loop of Henle. This is a nephron. So all diuretics affect our kidney nephron. The place of target of each of these diuretics, loop diuretics like furosemide, the strongest diuretics, they affect loop of Henle. Then we have the thiazides like hydrochlorothiazide. They affect the distal convoluted tubule mostly. And we have potassium-sparing diuretics, like, for example, spironolactone. They affect the collecting duct. So three very important group of diuretics would be loop diuretics, like furosemide and thiazides, and potassium-sparing diuretics, like spironolactone. Potassium, when you give diuretic, you cause electrolyte imbalance. Patient will have high or low level of potassium, low level of sodium, patient loses water and other electrolytes. Very important to know, loop diuretics like furosemide that affect loop of Henle and thiazide causes hypokalemia, low potassium level. So if patient is taking hydrochlorothiazide or furosemide, you should advise your patient to take foods that are rich in potassium, like, for example, more bananas or orange juice. In contrast, potassium-sparing diuretics like spironolactone, they causes hyperkalemia. They increase blood potassium level. So loop diuretics like furosemide and also thiazide like hydrochlorothiazide, they cause hypo or hypokalemia, low potassium level. Potassium-sparing diuretics like spironolactone causes hyperkalemia. Furosemide, that is a loop diuretic, is very important and a strong diuretic, has other side effects like, for example, photosensitivity, also causes, for example, increases blood sugar level, furosemide. So you need, and also, of course, potassium sparing. All diuretics and all antihypertensive drugs may cause orthostatic hypotension, means patient's blood pressure may drops when patient stands up. So orthostatic hypotension means patient has a good blood pressure, reasonable blood pressure when patient lying down. But if patient stands up quickly or sits down quickly, then patient blood pressure drops dramatically and patient may falls and have a head trauma. This is called orthostatic hypotension. It's side effects of all antihypertensive and all diuretics. So loop diuretics like furosemide. Side effects, hypokalemia, orthostatic hypotension, two unique side effects, or ototoxicity. So ask your patient to report any tinnitus and hearing problem. And also photosensitivity. Patient who takes furosemide should wear sunscreen. For hydrochlorothiazide and other thiazides, they also hydrochlorothiazide causes hypokalemia. Also, hydrochlorothiazide may cause hyperuricemia. I think it's the name, yes. For hydrochlorothiazide or other thiazides, thiazide diuretics, you need to monitor also uric acid level. If patient has history of gout, don't give them hydrochlorothiazide and other thiazides. Antihypertensive medication. If your patient has high blood pressure, you have different options to give to your patient, depend on your patient history. We have renin-angiotensin aldosterone system drugs that affect the renin-angiotensin aldosterone system. We have ACE inhibitors or angiotensin converting enzyme inhibitors that have suffix "pril", like captopril, enalapril, lisinopril. And we have herbs or angiotensin receptor blockers. They have suffix "zartan", like valsartan, losartan. So they both block angiotensin renin-angiotensin aldosterone system. We have calcium channel blockers like diltiazem, verapamil, and also amlodipine. Specifically, remember diltiazem and verapamil. Calcium channel blockers may worsen the congestive heart failure. So if your patient has congestive heart failure, weak heart, don't give them or try to avoid calcium channel blockers. Beta blockers, they have all suffix olol, so easy to remember: propranolol, atenolol, metoprolol, carvedilol. They all have suffix olol, the generic name. Beta blockers causes bradycardia, slow heart rate. So you need to check patients' pulse rate before you give beta blockers. And also beta blockers are not good for patient who has asthma. Patient who has asthma, you can choose or you shouldn't choose beta blockers as an antihypertensive. And vasodilators like hydralazine that you give for a pregnant woman that has hypertension. During the pregnancy, hydralazine is the safest. So now each of them, for example, captopril, if you have a question that asks a question that enalapril or lisinopril, captopril, whenever you see suffix pril, it's angiotensin ACE inhibitor, angiotensin converting enzyme inhibitor. When you give suffix zartan, like losartan, this is angiotensin receptor blockers. Now let's go over side effects and cautions. For ACE inhibitors or that have suffix pril, like captopril, enalapril, lisinopril, they are contraindicated during the pregnancy, absolutely contraindicated. So ACE inhibitors are absolutely contraindicated during the pregnancy. They may cause angioedema, means patient reports that I'm going to have my tongue is swelling. So this is an emergency angioedema. Dry cough, sometimes they cause dry cough. Patient can't stand it, so you change it to another drug, like, for example, losartan. Beta blockers, they have suffix olol, like atenolol, beta propranolol, or carvedilol. Two important points regarding the beta blockers. They cause bradycardia, slow heart rate. So if you have a patient that his or her pulse rate is less than 60 beats per minute, hold beta blockers. Don't give beta blockers. Hold the medication and contact the healthcare provider. And atenolol, other beta blockers are not good for patient who has asthma. Remember, all these antihypertensive may cause orthostatic hypotension and also drop blood pressure dramatically if you give too much. So low blood pressure could be side effects of all of them. Now, for beta blockers, bradycardia, slow heart rate, is very important, and also they are not good for patient who has asthma. Calcium channel blockers like verapamil or diltiazem, you don't give to patient who has heart failure. If patient has history of heart failure, low ejection fraction, you better go with ACE inhibitors like captopril, enalapril, like not calcium channel blockers. For ACE inhibitors, they have suffix pril, captopril, enalapril, lisinopril. They may cause angioedema. If patient takes captopril, reports that I'm going to have a very big tongue, my tongue is swelling, you tell your patient, call 911 or go to the emergency. Dry cough, most of the time patient can't stand it, you need to switch it to another drug. Pregnancy, they are absolutely contraindicated during the pregnancy. When you give captopril to your patient, make sure your patient doesn't want to get pregnant. And low blood pressure, that could be side effects of all antihypertensives. Drugs for treatment of hyperlipidemia. The type of drugs that you need to absolutely know are statins. Why we call them statins? Because they have suffix statin, all of them. Atorvastatin, lovastatin, simvastatin, they have all suffix statin. But their real name is hydroxymethylglutaric coenzyme A inhibitors, because they block this enzyme. And they decrease level of formation of all types of cholesterol, specifically LDL. VLDL, LDL, but specifically LDL. So they increase patients' life expectancy because they decrease risk of atherosclerosis for patient who has ischemic heart. But they have side effects. First of all, you don't give statins during the pregnancy. Why? Remember, baby's brain is all cholesterol, and you don't want to interfere with formation of fetus's brain. So statins are not drugs during the pregnancy. Second, they have two important side effects, myopathy and hepatotoxicity. So atorvastatin, lovastatin, simvastatin, they all have suffix statin. They are called statins. They are treatment for hypercholesterolemia. They decrease level of cholesterol. You don't give them during the pregnancy. Two important side effects of statins, hepatotoxicity and myopathy. Now you may get different scenarios. For example, patient who is taking simvastatin says that I have sore muscles. I get tired very early, and I can't do exercise. What should you do? You should stop the medication and check the, for example, AST, ALT level, or check, for example, electromyography. Make sure your patient doesn't have myopathy. Or patient who want to start statins for your patient. You need to check the liver function test and ask your patient to report any abdominal pain, jaundice, nausea and vomiting, weight loss that could be signs and symptoms of hepatotoxicity. And patient who takes statins like atorvastatin, simvastatin, lovastatin shouldn't take alcohol, shouldn't take acetaminophen, and shouldn't take grapefruit juice. So remember, grapefruit juice It's not for patient who is taking statins, because grapefruit juice block enzymes in liver that metabolize statins and increase blood concentration of statins. Statins are a lot of times subject for question. So let's do a quick review for side effects and adverse effects. Statins like atorvastatin, simvastatin, lovastatin, you don't give them during the pregnancy. Two important adverse effects, myopathy and hepatotoxicity. For myopathy, if patient reports any muscle soreness, any muscle tiredness, you need to stop the medication. For hepatotoxicity, check the liver function test. Patient shouldn't take alcohol, acetaminophen. Patient shouldn't take grapefruit juice. Anti-anginal medication. What is angina pectoris? Angina pectoris is chest pain because of the tightness in coronary arteries. So this is irregular coronary arteries that give oxygen and nutrient to heart muscles, myocardium. If a patient has deposition of cholesterol inside of the coronary arteries, this coronary artery would be tighter and tighter. So there is not enough blood circulation for the heart muscle. If patient does exercise, patient develops chest pain. That could be very severe. When the tightness reaches to 90%, even 100%, then patient will experience myocardial infarction. That patient has very severe pain, needs immediate angiography, a stent, and even coronary artery bypass. Anti-anginal medication are drugs that relax smooth muscles of coronary arteries. Relax this smooth muscle of coronary arteries, make the coronary arteries wider. So they could be relief at the time for patient who has angina pectoris. We have three important groups of anti-anginal medication: nitrates, beta blockers, and calcium channel blockers. Remember, drugs have different indications, like beta blockers and calcium channel blockers. Beta blockers and calcium channel blockers are treatment for hypertension. Both of them are treatment for dysrhythmia. And now you see they are treatment for angina, chest pain. So beta blockers and calcium channel blockers. Nitrate, they are vasodilators, mean they relax coronary arteries, smooth muscles, and make them larger so more blood reaches to the heart muscle. You can give nitrates as IV drips, as sublingual tablets or pills, or you may give them nitrates as transdermal patch, or even, for example, pomades. When you give ointment, nitroglycerin ointments, or any transdermal ointment, you need to wear gloves. Otherwise, you will get the same amount of medication as your patient. So whenever you apply transdermal ointment, specifically high alert drugs like nitroglycerin that may drops your blood pressure, you need to wear gloves and then apply ointment on your patient's skin. For skin patches, nitroglycerin skin patches, remember you need to apply a new patch every day and give 10 hours nitrate-free time to your patient to prevent the tolerance. How do you evaluate if a nitroglycerin is working for your patient with ischemic heart disease or not? Your patient, you ask about the pain, if your chest pain is better or not. So you give sublingual nitroglycerin to patient who has chest pain and ask your patient feels better or not. And then you can give another nitrate and another nitrate after 20 minutes, or give nitroglycerin IV. But if they don't work, then you need to call 911 because patient has constant pain, means patient now has a myocardial infarction. Patient needs to go for emergency angiography and a stent and even coronary artery bypass. Contraindications of nitroglycerin and all antihypertensive medication. Don't give them if patient has low blood pressure. Nitrates drop your patient's blood pressure. So if you have a patient, at the first place, patient has blood pressure 90/60 millimeter of mercury. This patient cannot take nitroglycerins, beta blockers, calcium channel blockers, none of them, because blood pressure drops dangerously. You call the cardiologist to take patient to the operating room. Antidysrhythmic medication, we talked about beta blockers like propranolol, sotalol, calcium channel blockers, new drugs like class 1, quinidine, diazepamide. They are, quinidine also is anti-malarial medication. And we have also, for example, amiodarone and digoxin, class 5. What is the best choice for your patient who has dysrhythmia? The answer would be type of dysrhythmia. What's the reason for dysrhythmia? If your patient, you look at your patient's ECG strip, if your patient has supraventricular dysrhythmia, tachycardia, bradycardia, or dysrhythmia, or ventricular, then the treatment would be different. The one that you usually get questions is digoxin. Digoxin is inotropic drug. What does it mean a drug is inotropic? Means a drug that increases the heart contractility of the heart muscle. So inotropic drugs like digoxin increase the power of the heart muscle. So heart muscle can contract strongly. Also, digoxin slow down the heart rate, like beta blockers. Digoxin slow down the heart rate. It's inotropic, so increases the heart muscles strength for contraction. Also slows down the heart rate. So precautions for digoxin. First of all, you check patient pulse rate. If your patient pulse rate is less than 60 beats per minute, if your patient has bradycardia, don't give digoxin, because digoxin, side effect of digoxin would be bradycardia. You need to check any change in ECG. Sometimes patient who takes digoxin might have very unusual ECG, even similar to patient who has myocardial infarction. And potassium level is very important. Low potassium level, hypokalemia, increases risk for digoxin toxicity. So digoxin is a drug that has very little or narrow margin of safety. How do you evaluate your patient before you give digoxin? Check patient's pulse rate. If patient has bradycardia, don't give digoxin. Monitor your patient ECG and check patient's blood potassium level, because if patient's blood potassium level is less than, for example, 3 milliequivalent per deciliter, patient already has hypokalemia, digoxin toxicity would be more in this patient, risk for digoxin toxicity. Sign and symptoms of digoxin toxicity, because you need to find it very early. If you find it late, even hemodialysis cannot remove digoxin. You need to give very specific antibodies, very hard to treat digoxin toxicity. So you need to find it very early. Sign and symptoms of early digoxin toxicity would be nausea and vomiting, and also anorexia. So patient loses appetite, has nausea and vomiting, and any problem in vision, blurry vision or yellow vision. Patient says that I see everything in yellow color, or everything is blurry. You need to check blood digoxin level. And confusion, palpitation, there would be signs and symptoms of digoxin toxicity. So nausea and vomiting, or anorexia, any problem in vision like blurry vision, confusion, palpitation could be signs and symptoms of digoxin toxicity. For high blood sugar level for diabetes type 1, you give your patient insulin. There are different types of insulin. We have rapid-acting insulin like Aspart and Rispro. They work in less than 15 minutes, so very quick. Short-acting insulins are regular insulin. It works usually between 15 to 30 minutes. Intermediate-acting insulins, insulin NPH, it works usually in 8 hours, reaches to the peak in 8 hours. Long-acting insulins like glargine and detamir, they don't have peak. So if you take your patient, if your patient is taking Detamir or Glargine, patient doesn't need any snack at peak because there is no peak. What is the most dangerous side effects of all insulin? Hypoglycemia. Hypoglycemia, low blood sugar level. So whenever your patient takes insulin, patient should take a snack at the peak. For example, if patient takes aspart insulin, patient should take a snack within 15 minutes or should take the breakfast. Regular within 15 to 30 minutes. Insulin NPH patients should take a snack between 7 to 8 hours after taking insulin. Again, for Glargine and Detamir, there is no peak. All insulins, you cannot give insulins by mouth because insulin is a small molecule, would be destroyed by stomach acid. You give insulins, all insulins via subcutaneous injection. So what is route of administration of all insulins? Subcutaneous injection. Regular insulin is the only one that you can give IV to. So all insulins, including regular, you give subcutaneously. Regular insulin is the only one that you can give IV to. For insulin NPH and regular, you can mix them together, and you should mix them together because you'd want to give less injection, less, for example, needle shot to your patient. So regular and NPH insulin can be or should be mixed to each other. How do you mix them together? First of all, you need to inspect the vial of insulin. Insulin regular should be clear. Insulin NPH most of the time is cloudy. But if regular insulin is cloudy, it's insulin that is contaminated. So insulin NPH is cloudy, regular is clear. So you inspect vial of insulin, then you inject air to the NPH and then air to the regular. When you want to withdraw, you start with the regular. Withdraw from regular and then withdraw from NPH. So the sequence would be you inject air to the NPH insulin and then air to the regular. When you want to withdraw, you start with regular. You withdraw from regular first and then withdraw from NPH and then give the injection to your patient. Insulin, you give by a subcutaneous injection. So you need to advise your patient, rotate site of injection. Patient should rotate site of injection. Otherwise, patient develops lipodystrophy. So patient once on the right side, left side, right thigh, left thigh. So you rotate site of injection to prevent lipodystrophy. Hypoglycemia is very scary, very dangerous side effects of adverse effects of insulin and also anti-diabetic medication. Patients, signs and symptoms of hypoglycemia, patient will feel hungry, patient would be very nervous, sweats a lot, weakness, pale, patient would be confused, and you should immediately give your patient a sweet. For example, if patient is still awake and can eat or drink, give patient orange juice or, for example, non-diet soda. If patient is not cannot drink anymore, if patient is confused, then you can give IV glucose. Anti-epileptic medications, we have traditional anti-epileptic like phenytoin, carbamazepine, valproic acid, and we have newer generation like lamotrigine and topiramate. For all anti-epileptic medication, remember, pay attention to the skin rashes. So, for example, patient who is a child is taking valproic acid and develops some rashes on skin. And you need to advise parents to check for any rash on patient's skin. And patient should immediately come to the clinic because skin rashes with anti-epileptic medication may develop to Stevens-Johnson that could be very dangerous. For all anti-epileptic medication, patient should not stop them, should not increase or decrease the dose. Would be very dangerous. Only the person who prescribed phenytoin or carbamazepine or ethosuximide can increase or decrease the dose or schedule for example, discontinuing, but patient cannot. For phenytoin, there are some nursing implications for phenytoin. Your phenytoin, if you have ever seen phenytoin, you have either IV or PO. You don't have IM or subcutaneously. Why? Because phenytoin is extremely irritating for the tissue. So you can't give IM phenytoin or subcutaneous, and you don't have those options. Phenytoin, either you give IV and you dilute it inside of the normal saline. So for example, 250 milligram of the phenytoin inside of 500 milliliter of normal saline, and you give infusion via 1 hour. So for phenytoin, you have either IV or PO, like tablets and capsules. You can't give IM injection because phenytoin is irritating for the tissue. For phenytoin and all anti-epileptic medication, pay attention to skin rashes because they may develop and cause Stevens-Johnson disease. Stevens-Johnson, like this one. Rashes would be very severe, disseminate alongside the body, disseminate inside of the mouth, inside of the eye, and may kill patients. So any rash in patient who takes anti-epileptic medications like phenytoin, you need to pay attention immediately. Also, phenytoin is hepatotoxic. So phenytoin may cause jaundice. Phenytoin, if patient takes phenytoin and develops yellowish skin and sclera, you should immediately inform the healthcare provider. Antipsychotic medications, we have typical and atypical antipsychotic medication. Typical antipsychotic medication like chlorpromazine, phenothiazines, and haloperidol. They have, some of them are stronger, like haloperidol, that is very strong. Some of them are weaker, like chlorpromazine. What is side effects of phenothiazines? Typical phenothiazine, specifically a strong one like haloperidol, extrapyramidal syndrome. What are extrapyramidal syndrome? We had it in Pharmacology 1 regarding other drugs, dopamine inhibitors for anti-emetic medications, but they could be very serious for haloperidol. When you give a shot, whenever you have a patient with psychosis, with psychotic attack, usually the treatment is 1 shot of haloperidol. But sometimes, specifically in younger patients, they develop extrapyramidal syndrome. Patient will have upward gaze, abnormal worm-like movement in tongue, contraction in muscle of neck and face. Patient will have puffing cheeks, smacking lips, abnormal or restless legs, akathisia, and also bradykinesia, all of them called extrapyramidal syndrome. You need to record all these findings and inform the healthcare provider. Treatment would be benztropine, and diphenhydramine. Most of the time, only antihistamine. So haloperidol, typical antipsychotics, specifically haloperidol, that is the stronger one, or fluphenazine, they may cause extrapyramidal syndrome. Atypical antipsychotics like risperidone, quetiapine, and also, for example, clozapine. They don't cause extrapyramidal syndrome, but they may cause metabolic diseases, like they increase blood sugar level, they may increase blood pressure. So they cause metabolic disorders. For clozapine may cause severe neutropenia, decreased number of neutrophils, white blood cells. So clozapine usually is safe for patient who doesn't respond to risperidone or quetiapine. They are atypical antipsychotics. For anti-anxiety medications, the most famous anti-anxiety or anxiolytics medication are benzodiazepines. Benzodiazepines, they have PAM most of the time, or for example, lorazepam, clonazepam. I'm talking about their generic name. lorazepam and other benzodiazepines, they are treatment for anxiety, but sometimes they may cause paradoxical excitement. What does it mean when you give a lorazepam to most of the time an older patient and patient gets more excited? This is the paradoxical excitement, and you should stop the medication. And remember, benzodiazepines are controlled substances. They are in Schedule 4 of controlled substances. All benzodiazepines, lorazepam, oxazepam, all of them are in Schedule 4 of controlled substance. For Alzheimer's disease, what is the reason for Alzheimer's disease? Patient develops some tangle protein amyloids deposition inside of the brain. Those protein beta amyloid inside of the brain start killing neurons or brain cells. You can't do anything for that for now. For now, we can't do anything to stop formation of protein amyloid inside of the brain. But at the same time, there is a problem in acetylcholine. Patients with Alzheimer's disease, they have low acetylcholine level inside of the brain. So medication that you give for treatment of Alzheimer, you in fact just make the sign and symptoms better, but they are not a treatment because you only increase level of acetylcholine inside of the brain. Remember, we don't have any treatment for Alzheimer, any cure for Alzheimer. We don't have any cure for Parkinson. We don't have any cure for epilepsy or even for multiple sclerosis. You have just medication that decrease the sign and symptoms and give your patient better life quality. So donepezil, rivastigmine, and memantine, they are treatment for Alzheimer's disease. If you see a patient who is taking donepezil or rivastigmine or memantine, you would be suspicious that patient probably has Alzheimer's. Donepezil is the most famous one, donepezil. Why? Because it gives a better life quality to the patient. Donepezil has two important nursing implications. First of all, fainting episodes. So you need to advise family members, patient who takes donepezil may have fainting episodes because it causes dysrhythmia of the heart. And don't take donepezil with dextromethorphan. So patient who takes donepezil as a treatment of Alzheimer's disease, advise family members that patient may have fainting episodes, so be careful. And if patient is taking donepezil, patient shouldn't take antitussives medication like dextromethorphan for treatment of cough. Drugs for antidepressants or drugs for treatment of depression. There are several types of antidepressants like serotonin reuptake inhibitors, SSRI, or for example, tricyclic antidepressant, or monoamino oxidase. Monoamino oxidase inhibitors are important because they have a lot of drug interaction and food interaction. Whenever you give your patient monoamino oxidase inhibitors like tronicyclovir, like selegiline for treatment of depression or for treatment of Parkinson's disease, you give your patient a long list of foods and drugs that are contraindicated. Foods that have tyramine. Tyramine is an amino acid, may cause severe high increase in blood pressure. So patient who takes monoamino oxidase inhibitor shouldn't take cheddar cheese, old cheese, smoked meat, or wine, avocado, because these foods have high level of tyramine. And tyramine plus monoamino oxidase rises your patient blood pressure to 200 millimeter of mercury. That is dangerous. Also, patient who takes monoamino oxidase inhibitors cannot take many other drugs, like, for example, beta agonists for treatment of asthma. Patient cannot take albuterol. Patient cannot take other antidepressants because they all have interaction with monoamino oxidase inhibitors. With mood stability, with antidepressant, Remember bupropion for smoking cessation. A lot of time you see this question, which of antidepressant you can give for smoking cessation? The answer is bupropion. Okay, so bupropion is an antidepressant that works for smoking cessation. Doesn't mean that it works for all patients. Maybe some 35% of patients may respond, but still you see in question. So for smoking cessation, the drug that could be helpful is bupropion. Then anticoagulants. Anticoagulants, and we have thrombolytics. What is different with anticoagulants and thrombolytics? Anticoagulants like aspirin, heparin, warfarin, they cannot dissolve clot that is already made. They just prevent formation of new clots. Okay, so anticoagulants like heparin, warfarin, aspirin, apixaban, they just block production of, prevent production of new clots. They are blood thinners. By thrombolytics like tissue plasminogen activator, they can dissolve clots that are already there, like tissue plasminogen activator. So anticoagulants, we have platelet inhibitors like aspirin, clopidogrel. They block platelets. Direct troponin inhibitors like apixaban, dabigatran, they are good because you don't need to check any lab tests. For heparin, you need to check PTT, partial tropoblast time. For warfarin, you need to frequently check PT and INR. But for apixaban, dabigatran, you don't need to check lab tests. Then we have indirect thrombin inhibitors like heparin, and we have vitamin K inhibitors like warfarin. They are anticoagulants or blood thinner. Why we give blood thinners or anticoagulants? To make the blood thin. If patient has, for example, AF, atrial fibrillation, or a prosthetic heart valve, there would be formation of clots, small clots inside of the heart, and these clots may go to the brain and cause a stroke, or go to the lung and cause pulmonary emboli. You give blood thinners or anticoagulants to prevent formation of, for example, a clot inside of the brain, otherwise patient develops a stroke. What is side effects, dangerous side effects of all of them? Bleeding. All of them, all blood thinners, all anticoagulants may cause bleeding. Heparin, warfarin, they are high alert drugs because if you give too much of them, patient bleeds. For heparin, is a high alert drugs, you need to have the antidote ready. What is antidote of heparin? Protamine sulfate or protamine. Protamine sulfate is antidote of heparin. If your patient is taking heparin, two nurses need to check the dose of heparin that you are giving to your patient. Make sure you are not making a mistake. And check the partial thromboblastin time or PTT frequently. So you can't, heparin, again, you don't have heparin PO. You have either subcutaneous or IV injection of heparin. And most of the time you need to check patient PTT 2 or even 3 times a day to make sure you are not giving too much of heparin. Side effect of heparin, heparin-induced thrombocytopenia. So sometimes when you give heparin, patient number of thrombocytes or platelets drops dramatically. So for heparin, for all anticoagulants, increased risk for bleeding. For heparin, check the partial thromboplastin time or PTT. Is PTT too long? If PTT is too long, you need to hold the next dose. Heparin, you either give subcutaneously or IV. We don't have PO, route of administration for heparin. And for heparin, you should have the antidote ready. Protamine sulfate is antidote of heparin. Warfarin is vitamin K antagonist. Warfarin takes 3 to 7 days to work. So when you want to give warfarin for a long time, for several months or several years to your patient, you start warfarin and heparin together. After 3 to 5 days, when warfarin reaches to maximum effect, then you can stop heparin and continue warfarin. For warfarin, you monitor PT and INR, prothrombin time and INR. So INR, international normalized ratio, should be 1 in a person, in a normal person. But you want to increase INR to 2 or 3. But if patient INR reaches to 4 or 5, then it's a danger for bleeding. Warfarin blocks vitamin K, absorption of vitamin K. So patients should have control over foods that are rich in vitamin K, like for example, kale, like for example, lettuce, spinach. They have too much of vitamin K, and patient who takes warfarin should avoid those types of foods. What is antidote of warfarin? Vitamin K. What is antidote of heparin? Protamine sulfate. So high alert drugs, you need to know the antidote. For what was the antidote of opioids? Naloxone. What is antidote of heparin? Protamine sulfate. What is antidote of warfarin? Vitamin K. And warfarin you shouldn't give during the pregnancy. If a pregnant woman needs blood thinner, give them heparin, not warfarin. Warfarin may cause skin necrosis, specifically for overweight women that are postmenopausal. Postmenopausal overweight women, when you start warfarin, during the first 3 to 5 days, you should be cautious for any sign and symptoms of skin necrosis. Side effects of all anticoagulants, including heparin, warfarin, aspirin, apixaban, they may cause bleeding, increased risk for bleeding. So check your patient for any easy bruising. This is easy bruising. Patient doesn't have any trauma, but has bruising. Easy bruising, gum bleeding, black tarry stool, black stool that is soft shows that patient has bleeding inside of the gastrointestinal system. Shortness of breath, because patient already lost blood and cannot breathe, doesn't have enough blood. And dizziness, abdominal pain, they all could be signs and symptoms of bleeding. When you give heparin, do not give massage on site of injection. So heparin is direct antithrombin 3. So blocks antithrombin 3 and make the blood thinner. If you give massage on site of injection, it may cause severe bruising. What is apoitin alpha? Apoitin alpha is synthetic erythropoietin. Remember, erythropoietin is the hormone that our kidney make. Erythropoietin stimulates production of red blood cells. So imagine if a patient has anemia, severe anemia, or a patient has end-stage renal disease, that kidney doesn't work and doesn't make erythropoietin. You give apoitin alpha, injection of apoitin alpha to stimulate production of red blood. But important nursing implication, when you give apoitin alpha, you should give iron supplement too, because when you give stimulation for formation of red blood cells, you should give enough materials for formation of red blood cells. So when you give apoitin alpha, you should give iron supplement too. Blood transfusion, you do cross match, but even after a cross match, when you give blood transfusion, patient may develop rash, urticaria, or even starts having, for example, shaking episodes. They are because of the allergic reaction to the proteins inside of the plasma or to the white blood cells. What should you do? You should hold the transfusion, stop transfusion, and give your patient antihistamine and inform the healthcare provider. So if you are giving your patient blood transfusion and patient develops rash, urticaria, even shaking episodes, you need to give antihistamines and stop the administration of blood and inform the healthcare provider. Treatment of hyperthyroidism. If patient has abnormally hyperactive thyroid, hyperthyroidism, you can give your patient methimazole or propylthiouracil. Both of them block formation of thyroid hormone. How do you know they are working? Patient will have better life quality. Remember thyroid hormones. Thyroid hormones increase the body metabolic rate. So patient with hyperthyroidism has, for example, always feels hot, sweats a lot, has tremor, has increased pulse rate, increased respiratory rate. So when you give your patient methimazole or propylthiouracil, patient will have a slower heart rate, patient will have less episodes of anxiety, patient doesn't feel that much hot, sweating decreases. So one way to check if methimazole and propylthiouracil are working, check your patient pulse rate, check your patient respiratory rate. If they are returning back to the normal, means these drugs are working. For treatment of osteoporosis, the most famous types of drugs are bisphosphonates. So you need to know about bisphosphonates. They have suffix. Sorry. They have suffix ronate, like for example, alendronate, risondronate. So they have all suffix dronate. You can, if you know, the alendronate is the most famous one, alendronate. They block osteoclasts. So when they block osteoclasts, they block absorption of calcium from bone, so they suppress osteoporosis process. For treatment of osteoporosis, you give the most famous type of drugs are bisphosphonates like alendronate, risondronate. They have suffix dronate. What is important nursing implication regarding the alendronate? Patient may develop esophagitis, means patient, the alendronate may stuck inside of the esophagus and create severe pain. So advise your patient when you are taking alendronate, remain seated or standing up for 30 minutes and take it with a full glass of water. So alendronate, risondronate, all bisphosphonates, patients should take them with a full glass of water and remain sitting or standing for 30 minutes to prevent stocking these tablets inside of the esophagus. You have this picture on your book, I guess it's chapter 15, immunologic drugs. Very important picture. If somebody catches disease, like for example, chickenpox, this is natural active immunity or active natural immunity. It's active because patient's body makes antibody. Patient's white blood cells, B cells actually makes antibody, and it's natural. If you get vaccinated, like a flu shot or COVID vaccine, that would be active artificial immunity. It's not natural, it's artificial, but it's still active because your B cells inside of your body actually make antibody. Passage of antibody from mother to the fetus or from mother to the, during the breastfeeding from mother to the baby is passive natural immunity. It's natural because baby's body, baby's B cells don't make antibody. They receive antibody from mother. Passage or infusion of antibody from one person to a patient, infusion of antibody that you gather from several people and then infuse it to their patient. This is passive artificial immunity. This is passive because this patient doesn't make antibody. He or she receives antibody from another person, and it's artificial. Unlike the mother to the baby, it's not natural, it's artificial. Which patient shouldn't take live attenuated vaccines? Live vaccines means vaccines like MMR, varicella. They have weak viruses, weak but alive viruses inside of them. If you give them to the patient who has a weak immune system, these viruses may create a real disease. So patients who have weak immune system, like history of HIV with low number of CD4s, patient who is taking glucocorticoids, or for example, DMARDs, not glucocorticoids, because glucocorticoids that doesn't cause that much of immunodeficiency. DMARDs, chemotherapy, they shouldn't take live vaccines. During the pregnancy, because varicella, MMR might be dangerous for the fetus. If patient had recent blood transfusion could be even the past 5 months. Shouldn't take live attenuated vaccine. If patient has family members with immunodeficiency that live at the same household, again, you should not give live attenuated vaccine. So live vaccines like MMR and varicella, you shouldn't give them during the pregnancy. You shouldn't give them to patients who are immunocompromised, a patient who have weak immune system, like patient who takes DMARDs and also chemotherapy, patient who have HIV, and the patient who had recent blood transfusion shouldn't take live vaccines like MMR and varicella. DTaP is diphtheria, tetanus, and acellular pertussis. So for 3 different diseases, DTaP, diphtheria, tetanus, and acellular pertussis, you give to children at 2 months, 4 months, and 6 months. Tdap is the adult form. It's again tetanus, diphtheria, and acellular pertussis. You give booster dose of Tdap to adults every 10 years. During the adolescence and adulthood, you give Tdap every 10 years. So DTaP, diphtheria, again, tetanus, and acellular pertussis, you give 2 months, 4 months, and 6 months to children. In adulthood and also in after the age of, for example, 10 years, you give Tdap. Tdap is a vaccine booster every 10 years. Meningococcal conjugated vaccine you give to all teenagers that wants to go to the college specifically, or they want to travel to, for example, a ceremony that lots of people are there, because meningococcal can be transmitted from a person to another person and create severe meningitis. All vaccines, including meningococcal conjugated vaccine, may cause allergic reaction. So if patient develops dizziness, weakness, swelling in tongue, lips, you need to immediately inform the healthcare provider. Okay, that was a quick review for your ATI exam. Good luck for your exam tomorrow.
Thank you so much.